Okay, next question is the consideration of second line treatments after progression on initial immunotherapy, whether it be Ipi-Nivo or a combination of anti-VEGF TKI along with immune checkpoint. Uh, Post immunotherapy, what is your thinking about the optimal second line treatment? Tian?
I think this is a really important question, Olga, I think there's some early days where we're thinking about sequencing after immune checkpoint inhibitors in the frontline setting. Danny Heng presented some interesting data from the IMDC database at GEO-ASCO 2019 about this, but largely the sequencing question has been unstudied. The VEGF-IO combinations really have been studied mostly in the early first-line setting without refractory disease data. And we really won't have randomized trials, I think, to test each of these sequences separately. And so in that setting, real-world data as well as registry data, some of the ongoing studies that are currently in development will really help us understand, what the different sequences will allow in terms of overall survival for these patients. We're also studying the sequencing question in an ongoing alliance phase 3 trial called Pedigree, which we'll talk about a little bit more soon. But the patients who undergo ipilimumab, nivolumab up front, and then followed by cabozantinib will have data about that as well from Pedigree. So I think it is really a data-free zone, and it's going to be difficult to think about how, what patients benefit, which patients benefit from immunotherapy after initial immunotherapy, or if we should switch mechanisms right away into a VEGF-targeted therapy after the early immunotherapy combinations.
Yeah, those are excellent thoughts. Do you think that the response to the initial immunotherapy should factor in, and if so, how, into our
Yeah,
second line decision?
sure, and we certainly are seeing some great responses from immune checkpoint combinations. So Ipi-Nivo patients. So we have some data now about treatment-free survival. So these patients who are coming off of Ipi-Nivo combinations up front, they have a certain time off treatment, and do they progress then 9 months after they've discontinued treatment? I think those are the perfect candidates for re-challenge in terms of they've had an initial great response, and now they should probably be re-challenged. In terms of early responding and or even early progression of disease, right? If they have 3 months on Ipi-Nivo, for example, and then they're progressing right away, really the immunotherapy probably is not doing very much in that setting, and so they definitely need another mechanism of action. And so there we have a lot of data from cabozantinib, for example, in the METEOR study, or other VEGF TKIs as well. So certainly the duration of the frontline treatment and how long they're responding and depth of response really does matter in terms of sequencing.
How does immune-related adverse events that occur during the frontline immune therapy, how do they impact the second line treatment decision?
Yeah, that's a great question. And our group is giving this a lot of thought right now, as many groups around the country are, because with nivolumab and ipilimumab, clearly there is a high toxicity rate. And there are patients that have to come off due to autoimmune colitis, autoimmune hepatitis, pneumonitis. In our practice, if patients have myositis or myocarditis and survive, we will not re-challenge them with immune therapy. If they have severe pneumonitis, we will not likely re-challenge them with immunotherapy. Colitis, we're starting to play around with some of these patients as they recover, because our sense is that it's largely driven by the ipilimumab. And so many of these patients, we're working with one of our fantastic gastroenterologists, Mimi Wong, and they're started on a drug which is called vedolizumab. And so she's studying that right now on a study, trying to see how well patients do on re-challenge in terms of if they re-flare their colitis or if we can keep them on drug. But as Tian said, some patients that develop these side effects don't progress and they're fine to be watched, but other patients, they start progressing quickly off of therapy and then you have to decide what to do. And those are some problematic areas. When I'm thinking about what to do second-line therapy, I'm again thinking about their rate of progression. I think a lot of times in the community, in some ways, they're kind of basing progression off of what the radiologist is saying as progression. And sometimes these are just very small millimeter changes in lung nodules or lymph nodes or in adrenal metastases or pancreas mets. And these are often patients that can be continued on the same therapy and don't even warrant a switch. But those are patients that I would probably think about doing a drug such as axitinib if they had not received that as their initial therapy. If they're really progressing rapidly, particularly in bone or in liver, and you really need to get a response, I think either cabozantinib or lenvatinib everolimus are very reasonable options at that point.